Assalamu alaikum. I am Dr. Mohammad A, Assistant Professor of Radiology, Cairo University. Welcome to our second mixed VIVA session. To interact with us, you can find the link of our WhatsApp group in the first comment of this video. Welcome to our YouTube channel, Easy Radiology Approach. So let's start by the first case.
Yes, sir. So can you scroll a bit downward? Yes, sir. Sir, I'm provided with the CT neck images, and I could appreciate that there is some collection with the thick enhancing wall and internal fluid density. It is located adjacent to the anterior to the left thyroid cartilage. So can you show me? Can you just move it a little bit upward? Yeah. Sir, I think it's inferior to the hide bone, and
Okay.
yeah, and I could not. It's between basically hide and thyroid, and I could not see any communication of it with or extension of it with between the carotid vessels. So,
Okay.
considering the imaging appearances, I'm thinking of some. My differential would include any necrotic lymph node, but there are
Yes.
no other lymph nodes in the entire vicinity of neck. The
Yes.
branchial cleft cyst, but that would be more between the IC and EC with the beak. The third differential would be a thyroglossal duct cyst
What?
and
Thyroglossal
thyroglossal
cyst.
duct cyst.
Yes. Okay. Okay.
Yes, but it's more in midline and sometime to slide to the left of midline, but mostly it's
Okay.
midline. And
Okay.
so yeah, these are my three differentials.
Okay. That's good. Okay. Very nice. Uh, I would like to add something very important here. As you said, we have here left paramedian, unilocular, pure cystic lesion, and this cystic lesion shows relatively thick wall, and at the same time, it doesn't show any intralaryngeal extension. It is located infrahyoid in location, and no calcifications, no solid components. These are the most negative points here. We don't have any solid components for calcifications. The first differential diagnosis, as you said, Thyroglossal cyst is very important. Thyroglossal cyst, the most common location is infrahyoid in location, and once we see infrahyoid in location, it is more likely to be paramedian, not midline. However, if we have hyoid location or suprahyoid, it is commonly to be seen in the midline. Okay, so once we have infrahyoid location of the Thyroglossal cyst, most likely it is off midline or paramedian, as we see here. This one is pathologically proved as Thyroglossal cyst, and it shows relatively thick wall, so maybe there is a possibility of infection. As I said before, we should exclude calcifications and the solid components to exclude any malignant transformation in this cyst. The second differential diagnosis in this case, as you said, cystic necrotic lymph node. So as you see here, you should scroll all the images and search for any primary malignant tumors. We don't have any other lymph nodes. We don't have any other masses. As you know, also Thyroglossal cyst, it appears along the course of the thyroglossal duct from the foramen of cecum till the thyroid gland. So I think it is enough here to finish this case. Thank you so much, candidate number 1. So we have a case of Thyroglossal cyst. Okay,
Thank you, sir.
let's move to the second case, please. Okay. This case, young adult patient complaining of slowly growing chest wall swelling.
Okay, I've been provided with the axial non-contrast CT images of the.
If you want to scroll, okay, as you like. If you want me to scroll for you.
Can you please scroll, sir, for me?
Okay, no problem. Okay.
I've been provided with axial non-contrast CT images of the chest in a middle-aged male who has been complaining with a left neck and chest wall swelling. At the outset, I can see a large soft tissue density mass involving the left anterior chest wall, uh, infiltrating the left pectoral muscles. And there's multiple other conglomerate axillary, retroperitoneal lymph nodes, axillary and retropectoral lymph nodes I can see, supraclavicular as well. On the left
Yeah.
side, there are multiple
Yes.
enlarged mediastinal nodes as well.
Yes.
There is no underlying rib erosion or intrathoracic extension of the uh, chest wall, left anterior chest wall lesion.
Okay.
I would like to look at the lung window to see because I spotted a left lower lobe lung
Okay.
nodular lesion.
Okay. I will show you what are your possibilities here in this mass. Before going to the lung window, do you have any differential diagnosis?
This would be neoplast. I'm thinking along the lines of a neoplastic etiology,
Neoplastic etiology. Okay.
given the multiple enlarged lymph nodes and the left chest
Okay.
wall tumors.
Okay. Okay. Let's see. I will show you the post-contrast study, mediastinal
I've
window.
been, okay, I've been provided with the mediastinal window contrast
Yeah.
CT images of the same patient. The soft tissue mass is mostly showing fluid density within, with
Yeah.
uh, likely probably due to cystic nature of the lesion or internal necrosis.
Yes. Yes.
There is the multiple enlarged lymph nodes I can notice are also showing some necrotic center with non-enhancing internal necrotic areas in the axillary
Okay.
and retroperitoneal region.
Okay.
Uh, there are multiple retroperitoneal nodes as well, which I could see in the lower, like upper abdominal sections.
Okay. So we have here a large cystic lesion. It
In the left
it is
anterior chest.
insinuated between the pectoralis major and pectoralis minor muscle. I think it is intermuscular location, and this one is, I think, unilocular. And
Yes.
I think we have also multiple axillary lymph nodes, as you can see here. And most of these lymph nodes are cystic in location or cystic in structure, consistency. We have also mediastinal lymph nodes. We have right paratracheal,
Yes.
and we have also few mediastinal lymph nodes, aortopulmonary, prevascular, precarinal. We have also, as you said, lower deep cervical lymph nodes here, or supraclavicular lymph nodes. Are you still thinking of neoplastic mass?
No, sir. Now, because of the predominant necrotic nature of the nodes and the mass, I am thinking along the lines of granulomatous infection, like
Okay.
tuberculosis would be my first differential. I would
Okay.
ask for any previous history of cough or fever or low-grade fever, or I would correlate with any history of weight loss the patient complains of.
Okay. And what is this one? What is this swelling? If we are thinking of tuberculosis infection or Graham's infection,
That is likely a cold abscess
cold
formation
abscess. Okay. Okay.
conglomerate infected lymph nodes.
Okay. Okay. Let's go to the lung window. May be helpful for you.
So I've been provided with axial lung window images of the same patient, CT
Yeah.
chest. Uh, I can see multiple scintillobular nodules scattered,
Yes.
with some ground glass opacities in the right
Yes.
middle superior segment of lower lobe as well as in the upper lobe.
Okay.
With some fibrotic changes in the left lower lobe as well. Uh,
Okay.
so this is in keeping with appearance of endobronchial spread of infection, likely like the triad opacities with endobronchial spread of infection.
Yes.
It would
Very nice.
support the diagnosis of active pulmonary tuberculosis with
Okay.
extrapulmonary involvement as
Very
well.
nice. Very nice.
I
Okay.
would
What's
I
your next
would
step?
I would refer the patient to the general physician for
Yeah.
sputum. For this is a active infection, so I will isolate the patient first. I will the advised Putam AFB test and
Okay.
advised Mantoux
Searching
test
for acid fast bacillus. Okay.
and
Yeah.
start anti-tubercular therapy
Okay.
accordingly.
Yes. Yes. Very nice. Okay. So as you said, I think we concluded together the findings. And as you said, this one is going with active tuberculosis infection. We have here, as you said, we have central lobular nodules, ill-defined central lobular nodules, and sometimes central lobular nodules show linear branching outline. Do you know this sign? When the central lobular nodules, yeah, three in bud infiltrates, three in bud infiltrates. Sorry, three in bud infiltrates indicates that we are dealing with acute infectious bronchiolitis, most likely in this case. We have another differential diagnosis, or we have other causes of three in bud, but this one, in this case, we have acute infectious bronchiolitis with transbronchial spread. And this case, pathologically proved to be cold abscess and active tuberculosis infection. Okay. Just I would like to add something here in this case. You should also search for any previous studies. And when I searched for any previous studies for this case, I found this CT neck for this case. It was done around 2 years ago. And as you see here, we have left supraclav or left lower deep cervical lymph nodes. And these lymph nodes show necrotic core. So we have cystic lymphadenopathy. Do you know the most common differential diagnosis for cystic lymphadenopathy, especially in the neck? Can you give me causes for this pathology?
There are neoplastic and non-neoplastic causes. In
Yes.
non-neoplastic causes, I would think of a granulomatous infection like a
Yes.
typical Mycobacterium
Lymphadenitis. Yes.
as well as atypical mycobacteria as well.
Yeah.
The non-neoplastic pathology, the non-neoplastic, the neoplastic pathology, I would think of papillary thyroid carcinoma.
Yes.
And squamous cell carcinoma of the head and neck.
Very nice. That's good. That's enough. So we have here, we should think for neoplastic etiology and non-neoplastic etiology, as you said. The most common neoplastic etiology is papillary carcinoma of the thyroid gland and squamous cell carcinoma in the neck. And the non-neoplastic etiology, most likely tuberculosis adenitis, as you see here in this case. Very nice and perfect. Candidate number 3. Thank you so much for joining me.
Thank you.
In this case, just I would like to highlight some important issue here. So this is a 3 in bud infiltrates, and I would like to review some important structures in the secondary pulmonary lobule. This is the secondary pulmonary lobule, and as you can see here, this is the pulmonary vein. Pulmonary vein runs in the interstitium, in the interlobular septi, while the pulmonary artery and terminal bronchioles going into the center of the pulmonary lobule. And once we have central lobular nodules or 3 in bud infiltrates, we should think what are the causes. We have the causes related to the terminal bronchiole, either pus inside the terminal bronchiole or inflammatory exudate, sometimes thickening of the wall of the terminal bronchiole or thickening of the bronchivascular interstitium. Also, we have here, if we have tumoral emboli inside the pulmonary artery, it will give us central lobular nodules and 3 in bud infiltrates. So think again, what is the structure of the secondary pulmonary lobule, and you will find the differential diagnosis. As you see here, this is the differential diagnosis of the 3 in bud infiltrates. 3 in bud infiltrates is considered as central lobular nodules or micronodules with a linear branching pattern. We have airway causes and we have vascular causes. The airway causes bronchiolitis filled with pus or inflammatory exudate, as you see in our case. Bronchiolitis, also thickening of the bronchial wall. Bronchiectasis, if it is filled with mucus or bronchiectasis. Broncholectasis, bronchovascular interstitial infiltration. And vascular intert, this is less likely and very rare, but it is considered one of the causes of the three. But tumoral emboli to the central lobular arteries, most common breast cancer and gastric carcinoma. Those are the most common causes of the three emboli infiltrates. Okay. Let's go to the next case. Next candidate. Where are you? Candidate number 3.
Yes,
are you
I'm
ready?
here.
Yeah,
Yes,
are
sir.
you ready? Okay.
Yes.
Okay.
Okay, sir,
This,
I'm provided. So should I start?
yeah, go on.
Okay, so I'm provided with coronal fat set images of
Yes.
MRI knee, in which
Yes.
I can appreciate that there is mild joint effusion is noted, and then
Okay.
the posterior cruciate ligament appears to be unremarkable, and I cannot see the
Okay.
anterior cruciate ligament in this provided view, for which I would like to review the sagittal images, and then
Okay.
menisci. I would take a look at the menisci. Okay, this is
Okay.
the sagittal view in which I can appreciate that there is a mild buckling of the posterior cruciate ligament is noted.
Yeah.
And I will scroll down to look at the menisci. There is a linear order signals are noted along the posterior horn of the meniscus, medial meniscus, and lateral meniscus is unremarkable. And anterior cruciate ligament, I cannot appreciate the anterior cruciate ligament. I'll scroll
Okay.
thoroughly to look. So
I am sorry to disturb
fibers.
you, but really,
Yes.
because you are picking up the findings very quickly and perfect. And I would like just to announce or to stop here. What
Yes.
are the abnormalities 1, 2, 3? You said the anterior cruciate ligament. Let us focus on the ligament first.
Yes, sir.
The anterior cruciate ligament, is it good or not good?
No, sir, it's not good. I cannot see its fibers, its
Yeah, it is
configuration.
torn. Yeah, it's
Yes,
torn
it is
and low
torn
line
completely.
because
Yes.
it should be parallel to the plummet line. This is a plummet line, while this
Yes,
is the anterior cruciate ligament, and we have here interruption of the fibers. Okay, and
yes, sir.
once we have interruption of the ACL, we should review our axial
Yes.
axial cuts, and I will show you. Okay, so ACL torn. Okay, the PCL, as you said, we have posterior buckling of the PCL,
Yes,
and
sir.
this is one of the secondary signs for ACL tear. Okay,
Yes, sir.
okay, quadriceps tendon and patellar tendon. It's okay. So let's focus on the menisci. Yeah, what do you see here in the medial meniscus?
So its posterior horn has a linear altered signal.
Yeah, you are
and
right.
It is not reaching the articular surface, so it's a grade 2 tear involving the
Do
posterior
you
horn.
think it reaches or not?
Yes, sir. It is reaching the articular surface.
It
Yes,
is
I
reaching
can see.
here,
Yes,
the
yes,
articular surface.
yes,
Okay,
yes, sir. Yes, and now I can see it's
okay,
reaching. So it's grade 3 tier.
okay. What do you have more here?
And sir, joint diffusion as well, and then I can appreciate that.
Let's focus on the medial meniscus.
Okay, so there is double meniscus sign as well with the flipping of the
we
yes,
have here.
Yes,
We have here
bucket handle tier of the plus. Yes, the
meniscal
loss
fragment
of both.
displaced. Yeah,
Yes.
displaced into the intercondylar region, just anterior to the PCL.
Yes. Yes, sir.
What is the sign?
Sir, it's a double PCL sign and
Double cruciate sign. Yes, double cruciate. So we have
bucket
here
handle.
bucket handle tear. Is it continuous or discontinuous? Sometimes the displaced fragment interrupted here, but this one is not interrupted. So this is a continuous.
Continuous, yes, sir.
Yeah, continuous bucket handle.
Yes, sir.
Continuous bucket handle tear of the body and the posterior horn of the medial meniscus. Okay, we have joint effusion. Okay, do you have any more?
Sir, I would review the coronal again to look for the collateral ligaments.
Okay,
have a look at the collateral ligaments.
Let's see the axial image before the coronal again. I will show you the coronal.
Yes, sir. Sir, in the okay, sir, in one of the collateral ligament, I think it's I will scroll down to confirm my side, which one is medial and which one is lateral, and
Which
then
one is the medial? Is this one the medial or lateral?
sir, where the bulk is more, that's medial, and or we can see from the fibula. So I think this is lateral, and the other one is medial. But
Okay.
I'll confirm. I'll confirm
This
while
is,
scrolling down and looking.
yeah,
Yes, sir. This
okay.
is lateral, and on
Okay,
the
this is lateral.
side where the bulk is more, that is the medial. Yes, sir.
Okay, okay. Do you have any
Sir,
abnormality in the collateral ligaments?
Sir, I can say, sir, in the lateral collateral ligament, I can appreciate there is an altered signal posteriorly, sir, and in the medial as well. I'm not sure. I
This
would review
area?
them in the
Yeah, I
coronary.
agree, totally agree with you.
Yes,
We have
yes,
here abnormal signal along
yes, sir.
the
Here,
posterior
exactly
aspect
here.
of the medial collateral ligament. Okay, and by the way, here, this is the interruption of the ACL in the axial
Yes,
plane
sir.
to confirm that we have complete thickness there of the ACL. And we have also joint effusion, and the
Yes, sir. Joint
PCL
effusion.
is normal.
Hmm.
It is preserving its continuity and normal dark signal. And also
Yes,
we have here high signal intensity along the gluteus muscle without
yes, sir.
fiber disruption.
With,
It is
yes,
considered as a grade 1 strain.
grade 1 spleen.
We have retinacular ligaments. I think all of the retinacular ligaments are intact.
Yes, sir. Medial and lateral.
Okay, okay. This one also is a coronal. I think the medial collateral ligament, it is surrounded by very ligamentous edema.
Yes, sir.
Okay, and we have also marrow edema along the lateral tibial condyle.
Condyle.
This
Yes,
is
sir.
secondary to the pivot shift impaction injury. Okay, so in conclusion, we have
So
ACL tear,
traumatic, yes, a traumatic knee injury
ACL
with
tear, medial meniscus
complete tear of
tear,
the ACL
bucket handle, and
bucket
we
handle
have
tear.
medial collateral ligament injury.
Yes,
And I
injury.
think it is considered as a low-grade tear injury
Yes,
or
sir.
low-grade injury for the medial collateral. Okay, what's your final diagnosis?
Sir, my final diagnosis will be bucket handle tear
Yeah.
with all these with complete tear of the anterior cruciate ligament, and yes, so it is called unhappy triad.
Yes, very nice. Okay, unhappy triad. Odongo, unhappy triad. These are the triad: anterior cruciate ligament tear, medial collateral ligament injury, and medial meniscal tear. Okay, very
I would
nice.
refer the patient to orthopedic surgeon for further
Very nice.
management.
Okay,
Yes,
okay, okay. Thank you so much.
Thank
Thank
you,
you so
sir.
much,
Thank you, sir.
candidate number 3. Can we go to candidate number 4, please? Are you ready, candidate number 4? Candidate number 4, are you ready, please? Candidate number 4. Okay, candidate number 5.
Yes, sir.
Candidate number 5, are you ready?
Yes.
Yeah, okay. Okay, candidate number 5.
Okay. So I'm presented with CT scan abdomen and pelvis, unenhanced study. First, I will like
Okay.
to scroll from top to bottom. Then I will start describing the findings. Okay. So on the unenhanced study, I can see that there is absent left kidney.
Okay.
And I do not see any gross pneumoperitoneum or pelvic ascites. I would like to know the history of the patient, if the patient has any known history of nephrectomy with the clinical notes. Um,
The patient is complaining of dysuria.
okay, there is some soft tissue opacification seen in the right pelvis. Uh,
So
there
you
is
said that
dilation
we
of
have
the
we
there is
don't
mild prominence.
we couldn't visualize the left kidney. The left kidney is totally non-visualized, and it is not present elsewhere. It doesn't
Yeah. There is no
present
evidence of any
the
ectopic
pelvis.
kidney.
Yeah, okay. Do you have any other
Okay.
abnormalities?
Um, the patient is okay. I can see that there is some soft tissue palsy seen posterior to the urinary bladder on the right side.
Okay,
Yes, this structure which is seen posterior to the urinary bladder is likely the patient is male. Can I scroll down?
okay.
Can we go more down, please?
Down, okay.
Yes, to just know the genitalia and know the gender of the patient. Okay, so in a male patient, I can see that there is marked enlargement of the prostate, and it
Yeah.
also appears
Is
hyperdense,
this
which is
one?
causing. Yes,
Uh-huh.
this rounded all prostate is
Do you think
enlarged and
is
appears.
this one is a prostate? This
Mm,
is a young adult patient.
okay, then this is something hyperdense mass lesion seen in the base of the urinary bladder. If the patient
Okay,
is having hematuria, there are some other satellite lesions seen
okay,
posterior to the urinary bladder.
okay.
And however, there is no hydronephrosis on the right side, and the right ureter is also unremarkable. So,
Yes.
it is likely an extrinsic lesion to the urinary bladder, which is submucosal or causing irritation in the
Yeah.
bladder. Um,
Okay.
okay. So I will like to proceed with the post-contrast images if available to further characterize the lesion.
Okay. So you want to have post-contrast study, okay, for this
Okay.
one.
Yes.
Do you have any more idea to characterize this lesion?
As I see that there is also left kidney was absent. So,
Mhm. Do you think the
left
MRI
kidney.
is helpful in this case or not?
Yes, yes, I think I should go with MRI. MRI would be helpful.
Okay. Let's see. I think this is MRI study for
Okay, on MRI
this.
study, it is a
Yeah.
cystic lesion.
Yeah.
Okay, and it is seen in the region of the seminal vesicle on the left side.
Okay.
Yes, and it is hypointense on T2 weighted sequences.
Very nice. Very good.
So,
Yes.
it could be related to the pathology of ipsilateral renal agenesis and a large cyst in the ipsilateral left seminal vesicle, which could
Yeah.
be due to Zinner syndrome, which is
Okay.
associated with this pathology. I will like
Perfect.
to see any previous images, if available, and
Okay.
any previous
Okay.
ultrasounds,
Okay. Okay.
or convey the findings to referring physician and MD discussion regarding the management.
Very nice. Can number 5. Well done. I
Thank you.
think, as you said, we have left renal agenesis, and we have here this is the right seminal vesicle, and the left seminal vesicle is not visualized. It is replaced by this large cystic lesion, and as you said, it displays ISO to low signal intensity in T2, so maybe proteinaceous content, maybe hemorrhagic content. And I would like just to add very or few other few tips here. We have here, this is the left ejaculatory duct, and as you
Mm.
see, the left ejaculatory duct is dilated, so most likely it is obstructed at this site, and also this is the left ureter, and the left ureter is going inferiorly ectopic position or ectopic
Mm.
insertion into the urethra, not to the urinary bladder. So we have here triad of Zinner syndrome. Zinner syndrome. Zinner syndrome. It is a triad: renal agenesis, seminal vesicle cyst, and obstructed epididymis. Okay, and we have here association associated anomaly, ectopic insertion of the left ureter. So let's review again the CT scan. This is the cyst, seminal vesicle cyst, and this is the ureter, and this is the prostate. This is a normal prostate. Okay, so this is, as you said, Zinner syndrome. Thank you so much, candidate number 5. Thank you for joining us. Can we move to candidate number 6? Are you ready?
Yes, sir. Assalamu alaikum.
Okay, candidate number 6. Okay. Candidate number 6.
Yes, sir. Sir, should I ask
Okay.
for control?
Okay. Yeah. Just a minute. Yeah, go on.
Okay. So I am going through the images. I've been presented with CT chest post-contrast axial images.
Okay.
And I can see that there is a well-defined hypodense cystic area seen involving the posterior muscles along the chest wall.
Yes.
And they extending up till the midline. The
Okay.
adjacent ribs appear. I'm looking to see if there is any rib erosion. Yes, I can see some rib erosion posteriorly with the extension of the collection anteriorly along the left lateral chest wall.
Okay.
Okay, so I want to see if there is intraspinal extension. Sir, are you scrolling? I'm not sure.
I am scrolling for you,
Okay.
please.
Okay,
I'm
thank
sorry.
No, it's okay. It's okay, sir. You
I'm
do
sorry.
it. No, sir.
Okay.
You do it, please.
Okay.
So I'm looking for any intraspinal extension. I do not see any, but I would rather do MRI spine for complete delineation. Here I can see there is erosion of some ribs. Yes, and there is extension anteriorly. And I noted some fibrotic changes, and yes, collapse of segmental collapse on the right side. Can I please see the lung window now?
Okay. I'm happy that you mentioned very important negative finding here, that this cystic lesion, as you said, it is centered upon the left chest wall, posterior aspect of the left chest wall, and it is continuous with the pleural surface, as you said here, with the pleural conduction, and it doesn't extend into the foramen, pleural foramen, and it doesn't show any intraspinal extension. This is one of the most important negative findings here in this case. And let's see the lung window.
Okay, so on the lung window, I can see multiple soft tissue opacities along the pleural, along the left pleura, and involving all these segments, with some cavitating lesions seen as well, and centrilobular nodules adjacently. There is no pleural effusion seen bilaterally. The heart and the mediastinum appears normal. On the left side again there is a segmental collapse. So sir, this looks like an infective process with a large abscess formation in the posterior muscles of the in the back, with left lung infective changes. And sir, I will this looks like a case of tuberculosis with the abscess formation. I would ask the clinical history of the patient, compare it with previous clinical images if available, and I will, if I will do the that isolate the patient, I will screen the close contacts, take the AFP sputum for culture, and do the tuberculin test and PCR testing, and then refer the patient urgently to pulmonology and surgery for the drainage of abscess, and and give the IV antibiotics, and then follow up the patient after treatment. And I will also look for extension of tuberculosis into the abdomen as well.
Okay, very, very nice. I think you concluded all the abnormalities, and this is a case of tuberculosis infection, as you said, and we have here multiple consolidative changes and central lobe nodules, and we have also, as you said, we have fibrotic changes and cavitary lesions in the left lung apex, and this could be old tuberculosis infection with super added acute attack or acute infectious attack. And we have also consolidation along the middle lung loop. And if we review again the pleura, this one is pleural collection, and the pleural collection is continuous with the posterior chest wall collections. So this can be spread from the pleural disease into the chest wall, making like cold abscess, as we saw before in one of our previous cases. So this one is called empyema necessitans. Empyema necessitans. Yeah, empyema necessitans means that the infection, it is not starting from the chest wall itself, but it is an extension from the pleural surface, pleural recess infection into the chest wall. Okay.
Yes,
so this one is called empyema resistance, and I agree with you that this case needs to be correlated with the previous studies, needs to be correlated with the clinical data, needs sputum analysis, and searching for acid-fast bacillus, and also it should be discussed with infectious disease MDTs, because this one is one of the complications of tuberculosis infection. Okay, thank you so much. Number 6, a child, 10 years old, and complaining of acute lower abdominal pain. If you want to scroll, okay, go on.
No, sir, it's
you want me to scroll?
Sir.
Okay.
Yes, sir. These are the axial T2 weighted MR images of a 10 years old patient, female patient, in which I can appreciate that there is a bulky left ovary. There are multiple follicles seen within the ovary which are peripherally displaced, and the stroma is seen centrally, while the contralateral ovary is visualized with the normal location of the follicles. I'm trying to look for any free pelvic fluid which is there alongside of the left ovary. Also, I can appreciate that there is a twisted or a bulky pedicle which is seen adjacent to the anterior pole of this, adjacent to the medial pole of this kidney. There is the location of this ovary is posteriorly. I would like to see it in any other view if available. I would also like to see the T1 to see any associated hemorrhagic component, because I'm suspecting that this is a acute torsion on the left side with a twisting of a pedicle. These are the T1 weighted images, and there is no active focus of hemorrhage, but few hyperintensities are seen within it, but no active focus of bleed. I would like to see the post-contrast T1 fat set images as well to see any adjacent or inside abscess.
Do you want to inject hair contrast?
Sir, T1 fat set with contrast, yes.
I think the contrast is not needed here. It's not mandatory in this case. Let's see the coronal plane, may be helpful for you.
Okay, so on the coronal, the same findings are redemonstrated. There's a bulky left-sided ovary with central stroma, peripherally displaced, multiple small, uniform-sized follicles, and adjacent rim of fluid. No frank fluid. There is no adjacent evidence of any loculation, any collection, any abscess. I would like to see the pedicle once again. Pedicle once again, which is not visualized. There is no evidence of any bony lesion. The contralateral ovary is normally visualized, so the findings are suggestive of acute torsion leading to enlarged ovary. But I think the ovary is still salvageable because it's internal. It is not showing any hemorrhagic foci or any focus of necrosis.
Very nice. Okay. So I agree with you. I am totally agree. with you. I totally agree with you that we have highly suspicious left side ovarian torsion. As you said, if we compare, this is the right ovary, this is the right ovary, and this is the left ovary. The left ovary swollen, enlarged, edematous. The stroma here is edematous, bright T2 signal, and we have peripherally located follicles, and the orientation of the ovary is totally different from this one. This one more or less horizontal orientation, while this one is vertical in orientation. And we have mild free fluid collection, mild free peritoneal collection, and we have also here very nice twisted pedicle. If you can see here, this is hemorrhagic focus in the pedicle itself. This is twisted pedicle of the left ovary. And also we have the left ovary itself. It is paramedian in location, just posterior to the uterus. Also the uterus itself, it appears small in size, maybe infantile size, but this one should be correlated with the sagittal plane to check the volume or the size of the uterus. But as you said, we have here highly suspicious left ovarian torsion, and this case was operated at once at the time, and alhamdulillah, thanks to God, it was still viable. And as you mentioned, that we don't have any hemorrhagic patches in the left ovary, so we don't have any signs of hemorrhagic infarction of the ovary. And alhamdulillah, the ovary was fixed successfully, and alhamdulillah was saved totally. So this case is left ovarian torsion. Just I would like to ask you, is it common in this age group?
Sir, it is. It can be there. It is common. It is seen in the young females as well.
Okay. So it is more common in the reproductive age group, especially if we have ovarian cyst or ovarian mass that may help to twist the ovary. But it is not common in this age group, 9 years, 10 years. It's not common unless we have a lax suspensory ligament, lax pelvic suspensory ligament. So it can be happened at this age group. So this is the message here. You can diagnose ovarian torsion at 9 years, 10 years, no problem. Once you have findings and the clinical data that you support your diagnosis, please raise this possibility. It's very important to raise it at the time, and immediately before reporting this case, please inform the clinician by this. We have chest pain.
Chest pain, okay.
Yeah.
This is frontal radiograph of an adult patient presented with chest pain. So I can see that there is increased cardiothoracic ratio, consistent with cardiomegaly. There's also a prominent hilar bronchovascularity. There is some reticular shadows within the lower zones. Sir, can you please window it a little bit so I can I request control or will not need it?
Go on.
Okay.
If you want to adjust.
Yeah.
Okay, go on.
Think from this. Okay. There is no pleural effusions.
Okay.
Okay, I'm suspecting bilateral upper venous diversion.
Okay.
There is some cystic changes and bronchiectatic changes in the bilateral upper zones. Also, and peribronchial thickening. So I cannot see pneumothorax.
Can you go by your checklist, please?
Yeah, there is no consolidations. Checking the bone.
Yeah.
And mediastinum appears. Mediastinal contours appear unremarkable. So
Okay.
I would. There is no retrocardiac shadows. So I would like to check the bones. I can't see any bone.
So you checked the lung fields, you checked the mediastinum, you checked the heart, behind the heart, you checked the breast, you checked the bones, you checked the soft tissue of the chest wall.
Yeah.
What is remaining?
Lung apices are unremarkable.
Lung apices is very nice.
Trachea is central.
Central.
The rest of the bones are unremarkable. I cannot find any obvious cause for
you have one missing point in your checklist. Very important and very important in the exam.
Okay. Diaphragm.
Okay.
There is lucency in the central diaphragm.
This is, it looks like.
But I think it's just an artifact. Yeah, bowel.
Yeah. Okay.
So I can't see.
Do you have any more abnormalities, or do you have any more findings in the subdiaphragmatic region?
I'm suspecting slight lucency here behind the right.
No.
That is not. Yeah, it's
no.
not evident.
Ignore this one.
Okay. There is no lines and tubes, so.
Okay. So can we? I'm sorry. Can I take the hand, please? Here?
Yeah. Okay.
Okay. Just a minute. I don't know, but really, do you have any abnormality in the subdiaphragmatic region? I don't know.
I think there is branching lucency overlying the liver.
Yes.
Yeah.
Yes.
I can see now.
Very nice.
So,
very nice.
So this might be either they are central. So either pneumobilia or portovenous gas. I cannot see dilated bowel loops to suggest bowel obstruction.
Okay. How can we differentiate between these?
The central one. So if they are central, like I think these are more central. So it's most probably to be biliary. Pneumobilia. If it's peripheral and reaching the liver surface, so it would it's most probably to be
very nice.
portovenous gas. So I would like to check the abdomen.
We did the X-ray abdomen for this case later on. Okay, and I think is it helpful for you?
I can see again
something.
There is I think there is the bowel gas shifted to the left side. So there might be hepatomegaly or right paraspinal mass. So I would like to confirm this on CT. There is no evident bowel obstruction.
Yes, very nice. We don't have any evidence of bowel obstruction.
Yes. I cannot see gallstones. No other abnormal.
We don't have any gallstones. Yeah. Very nice.
There is no obvious splenomegaly.
Yeah.
The bones appear unremarkable.
Okay. We don't have
No
any
lesions,
pneumoperitoneum.
surgically preserved.
We don't have any
no
signs of
pneumoperitoneum.
pneumoperitoneum. Very nice.
Yeah.
Okay, so as you said, we have a branching linear lucency overlying the liver. So we are thinking either portal venous gas or pneumobilia.
Pneumobilia.
It is more central. It's more going with pneumobilia. So
Pneumobilia. So
in
I'd
the
like to
X-ray
check
abdomen,
this.
we don't have any gallstone ileus.
Okay.
Or the triad of gallstone ileus. We don't have any bowel obstruction. We don't have shadow for the stones. We don't have any pneumoperitoneum. So what's your next step?
I cannot appreciate the right source.
Okay.
So I would like to call the referring physician and suggest urgent CT.
Okay, this is what we did exactly in this case. We requested to do CT scan for this case, and this is a pre-contrast study for the case.
Okay, this is the CT abdomen and pelvis with oral contrast, no IV contrast injected. Okay, I can see there is a mural thickening, diffuse mural thickening involving the ascending colon down to the cecum with adjacent inflammatory fat stranding and multiple mesenteric lymph nodes. I would like to, and the pneumobilia is confirmed again. I would like to trace it to confirm that these are within the biliary. Please.
Yeah. So this is a pneumobilia, as you said.
Okay.
It's not inside the portal vein, because if it is inside the portal vein or portal vein gas, we should exclude a very serious cause.
So
ischemia, we don't have it. Something
we
like
don't
this.
have any bowel ischemia.
Anyway, we did the arterial phase also for this case to exclude any sign ischemia because I think we don't have any evidence of inside ischemia. But let us focus on what did you see here? Yeah, in the colon.
Okay, so I would like to. Okay, because it's a long segment. Okay, I would like to see the appendix itself also, as the patient presented with abdominal pain. Okay, I cannot see it. Okay. So as this is long segment, I would first think about inflammatory causes. But I would also put in the differential neoplastic cause. I would like to check it in coronal if possible.
Coronal, okay. I will give you the coronal venous, okay.
Venous, yeah. I would also check the solid organs for any focal lesions. I cannot appreciate any hepatic metastasis or any focal lesions. Okay, so as this is a long segment and I think there is aneurysmal dilatation, and multiple lymph nodes, my first possibility would be lymphoma. However, as lymphoma is not as common in the large bowel.
Okay.
I would put differential.
So you are thinking of neoplastic etiology or non-neoplastic etiology?
If it's neoplastic, because it's a long segment, we can put in differential lymphoma, as there is still a preservation of the lumen.
Okay.
And of the,
but I would like to add something here, because we the stratification or the normal stratification of the bowel wall is lost. And this is marked thickening of the cecum mounting to form soft tissue mass lesion, and this mass lesion is infiltrating the pericolic fat planes, and I think it's going more towards a neoplastic etiology because of loss of the stratification, the normal stratification of the bowel. Also, we don't have any raised inflammatory markers, and also we have pericolic and paracolic and mesenteric enlarged lymph
multiple
nodes.
lymph nodes.
So
Yes.
I think neoplastic is more
More
logic
most
thinking
possible.
than
Yeah.
non-neoplastic. Yeah. Okay.
Okay.
As you said,
Okay.
lymphoma is one of our differential diagnoses because we don't have any bowel obstruction, and chronic carcinoma is also one of the differential diagnoses. Okay.
Okay.
What's your next step?
So I would refer this patient to MDT, colorectal
Okay.
MDT, for further
Okay.
evaluation and endoscopic biopsy
Okay. Very nice.
for
Okay.
tissue diagnosis. And
Okay.
I would complete staging for chest
Okay. Okay. Let's.
to look
Okay.
for
You are
any
right.
pulmonary,
Okay.
as I
I would
couldn't
like.
find any liver.
Yes, you should review the other.
Review. I would review the liver.
Can you
Yeah,
review
and the
the other?
testicles.
Yeah. Can you review the other organs?
There is some gallstones incidental,
Yeah.
but I
Very
would
nice.
like to check the
Gallstones.
liver
Yes, you're right.
again.
We have here some
I think
gallstones.
there.
Yes.
Yeah, I'm suspecting something in the right lobe of the liver, but here there might be a focal lesion here, but I'm not sure. In the peripheral, yeah, there is something in yeah, I think there is focal lesion in the, yeah, here segment
I think
7 and 8.
what?
Yeah, multiple here in the liver dome. Yeah, I think.
Do you have any focal lesions
7
in
and
the
8.
liver? 7 and
I
8.
think 7 and 8 is something.
I see. Yeah. What is in 7 and 8?
Not.
You are right. We have abnormality, but what is this abnormality?
There is the focal lesions suspicious of metastasis.
Is this one is
Peripherally
focal lesions?
enhancing. Which one? No, this is branching.
Yes, this is branching. What is this one?
Yeah, this is. This
Yeah,
is
you are right.
just increased intrahepatic biliary dilatation.
Okay. Can you check the portal vein itself? We have here, this is a portal vein. Okay. This is a portal vein.
Okay, there is, there is, okay.
Let's go with the portal vein. This is left side, left portal vein. Where is the right portal vein?
Yeah, there is thrombus in the left. Yeah, and these are the branches
thrombus,
of the left portal vein. Okay.
Yeah, of the right portal vein. Okay, and this one can explain the branching hypodenesis. Okay, and we have here, this is a pneumobilia, as you said, and by reviewing the case underwent biliary intervention before in the sphincter of OD, so this one can explain concomitant this sphincter. Yeah. And also we have abnormal morphological features of the liver itself, undulate outline and hypertrophied caudate loop, and the left lobe itself hypertrophied.
Changes.
So these cirrhotic changes of the liver, and we have splenomegaly, and I think we should check the bone also. Also, I think the ovaries itself are relatively bulky. This one I reported this one like this.
I have requested the control. Okay, so I have been provided with non-contrast CT brain of a child, I guess.
Yes.
There is no acute intracranial hemorrhage. There's no mass effect or midline shift. I can see on the first roll that there is a prominent extra-axial CSF space along the right anterior temporal lobe, which looks to be an arachnoid cyst given its location. Rest of the brainstem cerebellar hemispheres appear normal. Rest of the temporal lobes and the rest of the brain appears normal. I would ask for the history of patient and age of the patient, please.
The patient is complaining of headache.
Okay. Other than...
But this is a child patient, as you said. Yeah.
Okay. The intracranial vessels also appear normal. They are not significantly hyperdense. There's only a cyst along the right anterior temporal lobe.
The patient is complaining of headache following head trauma.
Oh, okay. So I'm looking at the extra-axial spaces to look for any hemorrhage. The midline falx appears normal.
Okay.
There is no collection along the
Yes.
extraaxial
Very nice.
CSF
Okay.
spaces.
Mhm.
There is no definite subarachnoid hemorrhage.
Okay.
The straight sinus and the internal cerebral vein seem slightly hyperdense. I would like to correlate that with the patient's hydration status. The sulci along here appear slightly hyperdense, but there's no definite hemorrhage here.
I think the
And
gray-white matter interface is preserved. And
the gray,
even this straight sinus and internal cerebral veins, this is a normal density, I think. We don't
okay,
have
okay.
something dense. This is normal density.
Okay, if the patient has reduced consciousness, there's no definite hemorrhage in this scan. But if the
Yeah,
patient has reduced
okay. The child is fully conscious,
okay,
just having a headache following head trauma.
okay. I want to look at the scalp. So there is
Okay.
a small swelling
Yeah.
along the right frontal
Very
region,
nice. Okay.
which
Yes.
looks like to be a scalp hematoma.
Yeah.
I would look
Very
at the
nice.
orbits. I would look at the orbits for
Mm-hmm.
any.
Mm-hmm.
Okay, so there is no significant soft tissue swelling along the right orbit. The intraocular the globes and muscles appear normal. There's no definite fracture here. I would ask for
Yes.
the bone window to look for any small fractures along the skull base and along the skull bones. There's no
Okay.
definite abnormality in the orbits or any soft tissue swelling
I think
along this region.
yeah. I am sorry to interrupt you. Yes, I think you concluded or you picked up all the findings. We have subgaleal small hematoma along the right frontal region, and we have right side extraaxial cystic lesion along the anterior temporal region or along the floor of the medial cranial fossa at the right side, suggestive of arachnoid cyst. Do you have something on the left side?
So I'm scrolling on the left side to look for any swelling
Similar
or
to the right
hematoma.
side?
Given the impact of trauma here, I would want to look at the left temporal lobe to look for any counter coup injuries
Yeah,
right
very
here.
nice. We don't have any yeah, very nice. Okay, this is
Okay,
the
so
most important negative finding. Also, we have also on the left side, we have small cystic lesion here at the same side.
okay, right here.
It looks like, yeah, small, no, not here. It's go more down. Yeah, this one. Yeah, this one
Yes.
is small arachnoid cyst on the left side. So we have here
Okay.
bilateral arachnoid cyst, incidental finding more on the right side. We should check the bone,
Yes,
as
sir.
you said. Let's review the bone. I'm sorry to take the hand.
Sure, sir.
Okay, just a minute here.
So I'm looking at the bones.
Yeah.
I cannot see any large fracture
Yeah,
here.
very nice.
The
Okay.
soft tissue swelling is seen along the right
Yes.
preseptal region. The lamina papyracea appears normal. There's no
Very
hemorrhage
nice.
within the mastoidea cells. The zygomatic arches appear normal. The sphenoid bones and pterygoid pets appear, I guess they're normal. I
Yes, very
cannot
nice.
see any fracture along the right frontal bone yet. I want to look at the skull base to look for any fractures
Yeah.
there.
Also, the coronary plane is very important to check the orbital
Yes.
floor, to check any blowout fractures. And we have just, I think we don't have significant bone remodeling for the arachnoid cysts, and the petrous bone is normal. All of these structures are normal. So these are important negative findings in any case of trauma. And as you said, we have bilateral extraaxial cystic lesions, most likely arachnoid cyst. And the other differential diagnosis for these cystic lesions is epidermoid cyst. And the MRI is very important to differentiate using the FLAIR and diffusion weight image. But I think it is more likely to be arachnoid cyst because this cystic lesion, CSF-like density, it is very similar to the CSF inside the ventricular system. It is more or less similar to the CSF inside the ventricular system. So this one is most likely bilateral arachnoid cyst, larger on the right side. Thing number 12.
Yes, sir.
We have this case. 45 years old, complaining of acute abdominal pain. Do you want to scroll?
No, sir. Please scroll.
Okay. Okay.
So I'm presented with a native abdominal CT scan study. I will scroll to the last cut and then give my comment. Okay. This is the last cut. Okay. The picture is fixed, and it's not moving. Okay. So the upper section showed actually no remarkable abnormality. There is significant fat smudging within the pelvic cavity, and also there is a long segment of a sigmoid colon appeared to be has that mural wall thickening and wall diverticulosis with the associated surrounding eccentric fat stranding. I believe there was a collection at a level lower than that.
Here?
Yes, I believe this is some collection with
very nice.
non-dominant or like a non-dependent air foci within it.
Yeah.
And also there is like another smaller collection at just distal to it. Is there contrast enhanced study, please?
Okay. Really, when I saw this one, I requested to do CT scan with IV and oral contrast, and this is the venous phase. We did this one in the next day.
This is an contrast enhanced CT of the abdomen. So both IV and oral contrast. Also, the upper cuts show no significant abnormalities, but the lower cuts within the pelvis confirm the finding seen within the on the native study. There is like a long segment diverticular. There is a long segment sigmoid colon mural circumferential wall thickening that showed enhancement, and also with multiple small diverticuli. And also this collection at a level lower than that. Yes, it appears to have an irregular rim enhancing, irregular enhancing rim. So, and I think this is I think this is a case of an acute diverticulitis complicated by abscess formation.
Okay. Okay, perfect. Do you have any more negative findings that you should mention?
Yes, I would. I should exclude obstruction. Any
very nice.
bowel obstruction.
Do we have any insane obstruction? We don't have any.
Actually, there was none. The colon of Abir and of normal diameter and the small bowel as well.
Very nice. Okay.
Any size of fistula formation within the adjacent
very
bowel.
Nice. Do you
or
have
with
any fistulas formation?
Actually, I can't appreciate it actually within this.
Okay. I think you should request coronal plane. Yeah, coronal plane. Coronal plane is very important in this case.
Yes.
Let's see together and let's focus here in the coronal plane.
Yes. Oh, there is a close attachment, and it's appeared to be this collection and the sigmoid, this part of the sigmoid colon appeared to be in close attachment to the dome of the bladder.
Yeah.
And this collection also appeared to be fistulating into the dome of a bladder at a point of it, with the air foci appears to be extending to involve the bladder wall as well. So there was no actually.
Do you think that how can I totally agree with you that we have long segment affection of mural wall thickening in the sigmoid colon, and let's review together again, please. I'm sorry to disturb you, but let's review the axial plane again. We have long segment of affection, and we have small diverticular out pouches, as you can see here and here, and we have pericolic fat plane, smudging of the pericolic fat planes, and as you said, we have here pericolic gas lucency, and we have cystic collection, thick wall cystic collection, just inferior to the sigmoid colon. And as you said, this cystic collection is in continuity with the dome of the urinary bladder, or intimately related to the dome of the urinary bladder. It is insinuated between the sigmoid colon and urinary bladder, and this
could raise the possibility of a fistula formation,
of abscess formation, and there is mural wall thickening of the dome of the urinary bladder. So we have secondary severe cystitis of the urinary bladder. Do you have any gross evidence of colovesical fistula in this case?
Actually,
what is the surest sign?
The surest sign would be the extravasation of the the oral contrast or the enema contrast.
What is the earliest sign to exclude or to confirm colovesical fistula?
I'm sorry, sir. I didn't hear it.
The surest sign is searching for any gas lucency inside the urinary bladder. Okay, if we have any gas lucency inside the urinary bladder, this is for sure we have colovesical fistula. But at this stage, we don't have a surest sign of colovesical fistula, but we have here an extension extending.
The collection.
We have the inflammatory changes is severe, and it is extending into the dome of the urinary bladder with severe focal cystitis at this area, but still at this time it's going to fistulize. It's going to make a fistula, but at this moment we don't have a sure sign of fistula formation. We should search also for any other fistulas formation. We should say that we don't have any colocutaneous fistula, coloenteric fistula. We don't have any evidence of peritonitis. We don't have any evidence of mesenteric vein thrombophlebitis or portal vein gases. Those are one of the common negative findings. Yes, you are right. How can we differentiate between diverticulitis and colonic carcinoma? Why this one is not colonic carcinoma?
The long segment affection and the presence of neural diverticular, no obvious structuring or mucosal ulceration. The colonic carcinoma would be a short segment involvement. It would have an irregular structuring and an irregular mucosal lining that cause an apple core appearance within the, and would cause an upstream obstruction of the proximal bowel loops. But here it's a long segment and appear to be localized.
Very nice. Long segment affection.
And associated.
It is not obstructing. It is not obstructing the bowel loops. We have different diverticular outlet pouches at the vicinity of this abnormality. We have a pericolic abscess formation and perforation. This
is specific for diverticulitis.
With diverticulitis. Fistula communication is more with diverticulitis. Also, clinical findings and laboratory findings is very important. Those findings should be correlated and should be reviewed. Also, what's your next step in this case?
This is an urgent this is a surgical emergency, so I would refer it for the surgical team for the abscess drainage and abscess drainage and antibiotic cover, and actually that's it.
It should be referred urgently to the surgical team to take a decision. Is it should we manage this case conservatively or by surgical intervention? This is their decision. But also we should do, if we manage this case conservatively, we should do colonoscopy 6 to 8 weeks after this acute attack to exclude colonic carcinoma. This one is very important.
Weighted images. I can appreciate that there is evidence of a small hyper intensity noted in the region of the pons.
This one?
Yes, this could be a cold infarct.
Old ischemic focus, maybe.
Old ischemic focus, yes. And there is a elongated hyperintensity noted just in the left paraventricular region.
Okay.
Yes. Otherwise,
let's go to see the FLAIR image. Okay, this is the FLAIR.
Yes. And the FLAIR image is also, it is hyper intense. I cannot see any other significant abnormality other than mild atrophic changes.
Okay. Okay, this patient is complaining of left-sided hemiparesis, acute attack of left-sided hemiparesis.
Acute attack of left-sided hemiparesis.
Yeah.
Okay. And there is no evidence of any hypointensity in the region of MCA bilaterally.
Okay. What is the most important sequence in this case?
Diffusion weighted image.
Diffusion, okay. Let's see the diffusion. Let's let's make it like this one. ADC map. I will give you the ADC map also. Make it here. Okay.
Yes, and there are multiple areas of diffusion restriction noted in the right paraventricular region.
Okay.
Which are, yes, there is diffusion restriction, multiple areas noted. These are in the region, in the territory of right middle cerebral artery.
Okay.
As there are multiple areas, yes, also noted along the right sylvian fissure.
Okay.
No obvious diffusion restriction on the left side.
Okay. So we have the acute abnormalities at the right side, at the right coronal radiata and centrum semioval.
Yes.
At the right parietal region. Okay.
Yes.
And the parietal occipital region.
Yes, yes.
More likely at the subcortical regions, but we have also some abnormalities cortical based at the right high parietal region.
Yes.
And the occipital region. Is that correct?
Yes.
Okay.
Yes.
What's your final diagnosis?
And as final diagnosis, actually all these are ischemic changes, but
yeah.
It could
acute,
be
acute ischemic changes.
Ischemic
Yes.
changes, yes.
Acute small infarcts. Okay.
Yes.
And this one is considered as chronic infarct.
Okay. Okay.
Do you agree with me? What
Yes,
is the
yes.
name for these abnormalities?
Sorry, what is the name of?
What is the name? If we have something like this, small acute infarcts at the coronal radiata and centrum semioval.
Sorry, I don't know the specific name.
Watershed.
Watershed infarcts. Yes, yes, yes. Watershed infarcts.
We have two types of watershed infarcts. We have external and we have internal.
Right.
Okay. External at these areas. This is the external between the territory of the ACA and MCA. Okay, for example, or the territory between the MCA and the BCA. This is cortical based, cortical and subcortical. But if we have something like string of pearls, this is the descriptive term for this area. If we have more than 3 lesions and each lesion more than or equal 3 millimeter at the centrum semioval, this is considered as a watershed infarct internal type, or as I said before, we have two types, either external and internal. These are the internal type of watershed infarct. Okay.
Okay.
So this is yeah. You can say we have small acute infarcts at the right centrum semioval, coronal radiata, and the right parietal region, considered as watershed infarcts internal type. Okay.
Okay.
Thank you so much. Candidate number 15. Candidate number.
Presented with sagittal T2 of the spine of the thoracic spine.
Yeah.
Where I can see that there is abnormal signal noted in 2 vertebrae, in the inferior end plate and superior end plate of the consecutive vertebrae. I would like to count 1, 2, 3, 4, 5. I think 8 and 9, T8 and T9, with loss of the intervertebral disc space in between these two vertebrae. This is a hypointense and heterogeneous signal noted in T2. I would like to check the signal. I can't see any other abnormal signal. The cord appear normal signal as well.
Very nice. Okay.
So I would like to. I can't see any also prevertebral collection or subdural collection.
Okay.
This is T1. It's appear. This appear hypointense in T1. Yeah, there's no other abnormality in the rest of the vertebrae or the cord. Is there any stair sequences?
Stair sequence, okay.
Yeah, in the stairs that appear bright signal. And I would like to check. Yes. Yeah. I think there is collection noted anterior to them, so I would like to check in the axial cuts.
Okay.
This is axial stair?
This is axial T2.
T2, okay. So in axial T2, okay, I can see that the vessel anterior to the vertebrae appear normal, no evidence of any aneurysms or affection.
Very nice, very nice, and it's very important negative finding, yeah.
There is bilateral mild pleural effusion noted. The paraspinal muscles is not affected. And I can't see any affection, intradural collection or vertebral.
This is axial T1.
Okay. There is this is T1, right? Okay.
Yes. Yes.
So I can see that the pleural effusion appear hyper in T1. So this is not
the effusion. Is it displaying hyperintense signal?
No.
This one is extrapleural fat. This one is not pleural effusion. Yeah. This one is very similar
to pleural effusion.
To this fat in the mediastinum. So it is extrapleural fat, but it is more prominent. It's not pleural effusion. Okay.
Okay. So yeah, there is no prevertebral or collection or on the muscles.
Do we have any paraspinal or not paraspinal, paravertebral soft tissue sheets or something or normal paraspinal? Is it axial T1? This one is a normal level. This is a border of the vertebrae, and this is a fat.
Okay.
By this area. Look for this one. We have like soft tissue sheets or.
Yeah, there is a bilaterally on the lateral side and the anterior as well. Yes.
Okay. What's your opinion here? What's your diagnosis?
I think I have differentials. This might be a case of spondylodiscitis.
Yeah, very nice. Okay, perfect. Okay.
Because it involves the intervertebral disc, so and I can't see any subligamentous spread, so or no other level affected. So I think this is pyogenic spondylodiscitis, not
okay. Okay, very nice. Okay, so we have here abnormal signal of the disc and marrow edema of the adjacent vertebrae and vertebrae endoplates, and we have also erosive changes and mild destruction of the superior endoplate of the lower vertebral body. And we have, as we said, we have bilateral paravertebral soft tissue sheets. This one, the most beautiful term here is phlegmon. Okay. And this phlegmon should be enhancing in the post-contrast study, but unfortunately the patient refused to have IV contrast. But as you said, it's one of the most important findings to check the spinal cord compression. And I think we don't have any spinal cord compression. This one is very important because once we have spinal cord compression induced by the intraspinal phlegmon. This one is considered one of the emergency situations. We should call the neurosurgeon at once. So this is very important. And I agree with you that the most likely diagnosis here is biogenic spondylodiscitis. I would like to share with you very important spondylodiscitis. The most important two types of the spondylodiscitis, either tuberculous or biogenic spondylodiscitis. Tuberculous spondylodiscitis, the para and intraspinal abscess are large and with thin margin, while the biogenic spondylodiscitis, the paraspinal abscess is small with thick margin. The level is important. Biogenic is more common in the lumbar, while tuberculous is more common in the thoracic. And also, it's very important in tuberculous spondylodiscitis to see multiple levels with subligamentous spread of the abscess and taking multiple different levels. And really, in my exam, in my FRCR exam, one of the long cases, it was tuberculous spondylodiscitis. Also, one of the most important points, the disc itself, the disc affection, it is early affected in the biogenic, but it is lately affected in the tuberculous spondylodiscitis. And by the way, this point is very important, and it was written clearly in the pathology literatures. The vertebral destruction is more common in the tuberculous spondylodiscitis, while the destruction is very mild in the biogenic spondylodiscitis. The most important point, again, the first point, the large, if you find spondylodiscitis with a large cystic paraspinal or paravertebral cystic spaces or abscesses, this is more common in tuberculous spondylodiscitis. And I think this case is considered as biogenic spondylodiscitis. Thank you so much. And thank you for the audience. Thank you for the volunteers who shared with me